Welcome to the International Childbirth Initiative 2025 Webinar Series. My name is Michelle Skaer Therrien. I am the Executive Director of the International Childbirth Initiative. We have several members of IMBCO here with us today. Deborah, do you want to say hello?
Yes, thank you, Michelle. Hi, everyone. I'm Deborah Pascali-Bonaro. I chair the International Mother-Baby Childbirth Organization and also co-chair the International Childbirth Initiative. And we have several IMBCO board members here. Ray Davies is there, Deborah Lewis, and a new member who's presenting today, Maria Alejandra Cardenas. We see you there. So great to recognize our board members that are here. Thank you, Michelle.
Absolutely. All right. So today's subject, as you've all seen, is legal threats to autonomy, choice, and informed consent in labor and childbirth. I will introduce you to our presenters in just a minute, but I will go through our usual introduction in case there are new people here. For those of you new to the International Childbirth Initiative, ICI provides a framework for the implementation of safe and respectful care, practice, and policies through the 12 steps for safe and respectful mother, baby, family, maternity care. We are implemented through individual health facilities through a self-evaluation, reflection, and goal-setting process that involves community participation. And we were created by the International Federation of Gynecology and Obstetrics, FIGO, the International Mother Baby Childbirth Organization, IMBCO, as Deborah has just introduced herself, the International Confederation of Midwives, the International Pediatric Association, and the White Ribbon Alliance. And we have, I think, actually probably 50 partner organizations who have endorsed ICI, and we're open to all birthing facilities who are willing to commit to delivering safe and respectful care. And I am thrilled to be introducing today's presenters. Katy Mayall is an international human rights lawyer and specialist in sexual and reproductive health and rights. And for more than a decade, she's held various leadership roles at the Center for Reproductive Rights, and she has recently launched her own consulting service. And then along with her, we have Alejandra Cardenas, who is a Colombian lawyer with over 20 years of experience in international law, human rights, gender, and reproductive rights. She led the Department of Legal Strategies, Innovation, and Research at the Center for Reproductive Rights, and she has served as the Regional Director for Latin America and East Africa at Women's Link Worldwide, an intersectional feminist, anti-racist, anti-ableist, and anti-colonial human rights organization. Before her leadership position at Women's Link, she was a human rights expert with the Inter-American Commission on Human Rights, the primary and autonomous body of the Organization of American States, responsible for promoting and protecting human rights throughout the American continent. So you can see that she is extremely well qualified to take us through today's subject matter and provide us with insight along with Katy. So please, as we go, put your questions and comments into the chat. We're going to have hopefully a very lively discussion at the end of this. And with that, I am going to pass this over to Katy to introduce their research that they had done together.
Thank you so much, Michelle, and thank you, ICI, for having us here today. Can everyone hear me okay?
Yeah.
Okay, wonderful. So I'm so excited to be here today to share, or just to introduce the research that Alejandra and I have led in our previous capacity in our roles at the Center for Reproductive Rights. So over the past, I think more than the past several years, but for a long time, Alejandra and I have both recognized that the legal and policy frameworks surrounding maternal health and rights are simply inadequate. They're formulated in ways that undermine reproductive autonomy, choice, and informed consent in labor and childbirth, and prevent birthing people from having access to the decisions that they need to make informed decisions about their own bodies, their own lives, and about how they want to give birth, where, and with whom. As a result of that, Alejandra led the process to overhaul the strategy around maternal health at the Center for Reproductive Rights, which led to two key cornerstones of a revised strategy that sort of underpinned two pieces of research that we'll be sharing. And the first piece today, and the next one at the one of the ICI webinars in August. But essentially, the two areas that we saw of being really in acute need of an overhaul for how law and policy approaches them are both around autonomy during labor and delivery, and also throughout pregnancy, sort of as a whole, but also in regards to the midwifery model of care and the way that laws and policies undermine the midwifery model of care in countries across the globe. And so this presentation will be the first of those two companion pieces that are really two sides of the same coin, right? That are really about centering the decision-making of pregnant and birthing people throughout the duration of pregnancy, childbirth, and the postpartum period. And so I'm really excited for folks to hear this first piece of research, which is just really important and really, in my mind, a game changer about how we think about how disabling legal and policy frameworks are in regards to pregnancy and childbirth. So with that short intro, I will hand it over to Ale, who will take us through the research itself.
Thank you, Katie. Hi, everyone. I'm so happy to be here with you this morning, afternoon, or evening, depending on where you are. As was explained, we're going to present the findings of research that we did. It was global in nature around legal threats to autonomy, choice, and informed consent in labor and childbirth. Oops. Okay. So I think briefly it's important to just situate the landscape analysis that led us here. So there are, I'm obviously oversimplifying it, but these are some facts that I think are important to keep in mind. When the international community, the donors, like public health internationally, started to pay attention to maternal health, there was this huge push and this huge investment towards maternal health. And it is true that for some decades, specifically from 1990 to 2015, there was a significant reduction in maternal mortality. And I also want to stress that the emphasis for a long time was only on mortality. So the goal was to have a surviving mother. And because that was the emphasis, then things around how that happened were not necessarily the focus of the attention in policy making and investment. But we also know that in spite of that effort, since 2015, there's been an stagnation to that progress. So even in terms of surviving pregnancy and childbirth, there's been an stagnation, and there's some regions in the world where that progress has actually regressed. There's been a regression. And then the other thing that's important to I think keep in mind is that the focus, as I said, was on reducing the maternal mortality ratio, and that came with a whole mindset that the way to do that was to increase the rates of facility childbirth. So very specific mindset of a hospital type of birth. And then the other thing that we know is that more and more there's studies after studies around the world that tell us that there's a crisis in mistreatment. Women and pregnant people are going through pregnancy, labor, childbirth, and postpartum experiencing high rates of mistreatment. We did this research first, just reading everything under the sun that had been written about respectful maternity care, the crisis in mistreatment. And then because we're lawyers, we started getting very legal, right? So we chose 12 countries in 5 different regions of the world because we wanted a good sample of how this presented in countries that had very diverse and different socioeconomic GDPs, like the way their healthcare is organized, very different types of healthcare settings and outcomes. But so those countries were Brazil, Colombia, Mexico, the United States, Romania, Spain, India, Pakistan, Bangladesh, Kenya, Malawi, and Uganda. And we went down to do a whole legal mapping on what was going on in those countries in terms of regulations and in terms of how it was understood, what rights were understood, people undergoing, like going through healthcare for pregnancy, labor, and childbirth had. So I would like to just mention some key concepts, legal concepts, because under international human rights law, which most of these countries, except for the US, all of the other actually have commitments to respect and protect and fulfill. And even in the US, there's some rights in terms of bodily autonomy, in terms of privacy, that are still recognized constitutionally. So the first concept is the right to bodily autonomy, and that refers to the right to control one's own body, right? We are all owners of our body and our health. Nobody should do any interventions to us that we have not consented to, right? We are still the agents of anything that has to do with our bodies. That it relates to the right to freedom of choice, and that means that we all have rights to access meaningful choices when it comes to our own bodies and our own health. And then there's perhaps the most important right. It's the right that has been more, it's like almost that sacrosanctum right that was particularly developed after the horrors of the Second World War, in all the experimentation and all the horrendous things that happened to people's instrumentalization of people's bodies, particularly by the Nazis. And that is the right to informed consent, right? So under international law, it was recognized this as one of the most important rights when it comes to your body, right? And it has to do with, again, your bodily autonomy, your freedom of choice, and it is the right to make decisions about any intervention to your body, any intervention to your health of any kind. And that right implies that you have to know, it's informed consent, because you have to know, you have to have been provided information that is accurate, that is objective, that is scientifically based about the risk, the alternatives, and about the benefits of any intervention that is being presented to you that you might or might not consent to. And that is tied to the right to refuse. Inherently in the right to consent is the right to refuse. Now, there's always been some exceptions to that rule that is like a golden rule, right? And that is in cases of emergency situation, that is in cases where you're literally talking about saving someone's life or trying to impede like some big harm to their health. And it's an emergency because that risk is tied to an urgency. And that is important because it's not any type of risk. It's a risk that is tied to an urgency. There is a situation of urgency in which, it precludes a timely, in-depth discussion about the risk. But that has to be paired with two other conditions. And that is that the patient has to be incapacitated. So it's not just that there's an urgency, but that the patient is not in capacity to make a decision. And that means unconsciousness, delirium, like a traumatic brain injury. Like it's extreme situations in which you can totally say that the person has no legal capacity to make a decision. But then, even in those cases, you have to only do treatment that is in the immediate benefit of the patient. And at the last requirement is that there should be no advance directive or served. Okay? And this is something that is not only recognized under international law and by human rights courts around the world, constitutional courts around the world. This is language that the professional associations of emergency medicine around the world, the European Emergency Medicine Academy, the American Emergency Medicine Academy, like most emergency medicine academies agree and abide by these requirements that all of these elements need to be present. Again, in emergency situations. So when we did our research, we had two big overall conclusions. The first one is that there are actually more legal protections for the decision to have an abortion than to protect autonomy and decision making during pregnancy and childbirth. What we found, and I'll repeat this, is that you have more protections if you want to decide to have an abortion than if you want to make decisions sometimes has what you're going to be wearing while you're in labor, if you're going to be able to have a sip of water, right? So unfortunately, the difference of what protections you have is stark. And the other one is that we found that maternal health is the only field in medicine and law in which informed consent can be overridden and patients can be forced to submit to compulsory treatment against their will. So this is the first problem. The first problem is that most of these legal frameworks have ambiguous and overly broad exceptions to informed consent. The first thing is that almost universally, there's an equation between emergency and risk, which is not the same. And as you all know better than me, because you all have committed your lives to helping women and pregnant people give birth, there's no such a thing as a risk-free experience when you're pregnant and when you're going through childbirth. But the problem is that most of these equate emergency with risk, which is, again, not the same. The second one is that some regulations, for example, in Kenya or Colombia, do not require the patient to be incapacitated to consent. So they just say, yes, it's an emergency situation, but they don't say that patient has to be incapacitated. So it's an emergency, but even though you're perfectly capable of making decisions, I'm going to make them for you. The other one is, which is we found pretty typical, is language that makes it very subjective. If the provider feels that the requirement is not necessary, literally says feels. If in the opinion of the provider, the requirement can be waived. So completely subjective. There's another problem, loose definitions around capacity. Concepts of women are altered, women are agitated, women are getting violent, women are vulnerable. Again, all one subjective, two completely against any other field in law in which that is definitely not any of those qualified as making you incapacitated to make decisions. And in other instances, it's spoken as a right that you only have for invasive procedures, which is absolutely not true. Like under international law in any other field in healthcare, you have a right to informed consent in any type of intervention. The other problem is that legal frameworks may humanize care and choice during labor and childbirth contingent on good health status. So we have, for example, yes, you have a right to vertical birth if the space and the personnel allow for. Or humanized birth is your right, as long as the health conditions of both the women and the fetus allow it. Pain relief, yes, you should have alternatives other than the epidural if the health of the patient or the fetus allows for it too. The other one that we found is very common is the withholding of information from patients. What some people call therapeutic privilege, which is something that's completely against international law. There's all these standards that said, in Kenya, for example, if the provider considers that it's not in the best interest of the patient to know what's going on. If it would harm the patient, Brazil. If it would harm the mental or physical health of the patient. Or in the US, if it is medical inadvisable. So somebody is going to decide that you're not tough enough or you're not ready to know what's going on to you, what risks you're undergoing, what alternatives you might have, right? It's absolutely against the standards. Mistreatment across the 12 country studies was a constant. And when we look at the studies, we try to put an emphasis on loss of autonomy or lack of informed consent. And as the numbers tell you in this slide, that was so normalized. So at least 15% of women across the targeted countries, the 12 countries, have experienced this type of mistreatment. In some countries, it's almost universal in some of the studies, as India, Pakistan, and Romania. And non-consensual care is reported as the most common form of mistreatment in Mexico, India, Spain, and Romania. In Bangladesh, 53% of patients reported either moderate or severe levels of disrespect and abuse, and 13% of women reported non-consensual care. In Malawi, a study found that in 40% of births, there was a lack of consent and engagement in the decision-making process. So these regulations that I mentioned, right, the right to withhold information from you, say that, yes, you have a right to a humanized, a respectful birth if the conditions are offered. Like all of these things, it's not a coincidence that then we're seeing all this self-reported, by the way. This is not even like, this is self-reported non-decision making, not being able to participate. So the numbers might actually be higher. When we had this discussion with the people at WHO, whose job is to actually investigate this, do research on this, they were agreeing with this. That is, the numbers must be higher because these studies are often just on what people perceive was done to them without their informed consent. So the other big problem that we see is that there's been this huge push for humanized birth laws, recognition of obstetric violence. Like there's been a lot of like really good attempts to address the issue. But we found that one of the problems is that some of these approaches are about criminalizing providers with very broad definitions of obstetric violence, such as in Mexico, for example. So we are trying to solve this, one, with laws that are not really giving you a right to exercise that choice. But when you're not, we're giving like this broad spectrum of mistreatment, a solution that is about criminalizing someone's behavior, which, by the way, is not working. It's not even it's not even really addressing the problem. We can talk about that during the discussion, but I wanted to put it out there. The other one is that these solutions do not factor or address the conditions in which providers work and whether they are conducive to providing respectful care. So we know that if the system is collapsed, if there's one provider for 30 women in no help, like, no, there are no like material conditions and so on and so forth, like how can we expect this provider to have actually gone through a process of informed consent, a process of respectful care? And we do have to acknowledge that that is a big problem. And that is why if we only make it a subjective problem between the provider and the patient and we lose the systemic, we're not going to be addressing a huge part of what's going on. And then the last thing is that we are not resolving the legal tensions between, hey, let's respect human rights, let's make sure that women have positive childbirth experience, with the fact that most legal frameworks are not even really giving you the right to exercise that agency, right? And there's a conflict there with the legal environment. We're not providing people with autonomy. We're treating them more like they are so vulnerable and what they need is some sort of tutelage as if they were little kids. And therefore, we're allowing someone else in a whole system to decide on us, right? On us as when we go through pregnancy and childbirth. So there's some concepts in tension, and I think that they show what they are missing. So on the one hand, as I said, there's this important recognition of obstetric violence, but my concern with that is when we lose, when we narrow it to a problem that is interpersonal. It's like a provider that doesn't want to respect me and I am being disrespected. And we lose sight of the fact that I'm not even They are not even having clarity that I should be standing from a point of agency and empowerment, and I should be exercising those rights. And on the other hand, we're losing sight of the conditions that are not allowing for that experience to materialize. We are curtailing patient-centered models of care. On the other hand, there's this concept of vulnerability. Oh, we are not, it's like as if we suddenly become, 2-year-olds when we become pregnant. And what we need is someone to tell us what to do and how we will do it. No, we still remain fully capable. You can still be having contractions and make decisions. And this is a huge problem. Like this idea that because you're in pain or you're in labor, then you need someone to decide for you. That's completely wrong, and it's against everything that we're trying to solve for here. So again, there's legal tensions and misalignment. And what I think it's also at the core of all of this is that there's this artificial tension between either you respect the person, you give them autonomy, you understand that they deserve a positive childbirth experience, or you have a surviving newborn and a surviving mother. As if those two things were impossible to really have together at the same time. And often in the name of this artificial idea that you have to save both have a surviving mother and a healthy newborn, then you have to ditch the rest. And this is an idea that pervades everything, all the court decisions around these issues, and so on and so forth. Before I go to recommendations, I think I skipped this, which has to do with the last point I made, which is that refusal of care is overridden in the name of fetal protection. And this case is very telling. It was the case of a woman who was trying to have a vaginal birth after a C-section. And she was mandated by court to be forced to have a cesarean because they decided that the risk was too big for her to make a sound decision, and they needed to protect the fetus. And it's so interesting because when this case took place, the expert witnesses were so all over the place about what the risk of a vaginal birth after a C-section was. In some cases, they would throw like 10%. Now we know, based on the good science and like objective good studies being carried out, that the risk overall is less than 1%, right? But this woman was literally forced, like by the police, by a court, to have a cesarean section for something that is less risky than riding an airplane. So what risks, who is deciding what risks is worth taking, right? Because this is the only field in law or in medicine when we're seeing this. Something that is less than 1% risk is forcing women around the world to have C-sections, because this case is illustrative, but we're seeing this across the world. And it's such a low risk compared to choosing not to have, a man who decides not to get chemotherapy for prostate cancer, and nobody would ever force him. Like nobody would ever send him the police to force him to have chemotherapy. But less than 1% suddenly becomes something that it gives everyone a right to choose for you. So it's not really realistic. It's not really based on science. It's just this, any perceived risk suddenly makes you incapable of making decisions around your body and around your pregnancy and childbirth. So very quickly, our recommendations after all this research is that we need to anchor the legal frameworks in human rights-based approaches to maternal health. We have to legally make clear that pregnancy and labor do not constitute an exception to fundamental rights, including the right to informed consent and refusal, and the right to make decisions that may contradict medical advice, and the right to choose the mode, the location, and the circumstances of your own birth. We need to clearly find emergency exceptions to informed consent, noting that labor, pain, emotional distress, or disagreement is not a condition that incapacitates you to make decisions. We need to protect the right to refuse treatment, even when such refusals are believed to pose a risk to the fetus, because again, in most of these cases, they are just discrepancies about how to better achieve a live birth or a healthy birth, not a certainty that you're actually making a decision that will be fatal. There's no risk-free childbirth experience, and the best way to protect newborns is to support dignity and autonomy of the childbearing person. We need to prohibit coercive practices. We need to avoid punitive approaches that focus on criminalization of providers, with efforts to address mistreatment, prioritizing system-level reform to enable dignified care. And we need to implement mandatory training and data collection on rights and dignity in pregnancy, childbirth, and the postpartum period. Okay, I'll leave it there so we have time to discuss.
Thank you so much, Alejandra. That was really, I think, a lot of information presented in a very clear way. So, and I think that we're also seeing that people are responding in the chat. To this, so I've gone ahead. I don't know if anyone would like to unmute because we've got a few questions and a few comments that people have put into the chat. Please go ahead and put more thoughts and questions for Alejandra and Katy. But I'd like to know if anyone would like to go ahead and unmute and make their comment or ask their question. And you can raise your hand or you can unmute. We'll see if it gets hectic.